A nurse is caring for a patient with acute respiratory distress syndrome, ARDS, on mechanical ventilation. The ventilator is set at tidal volume 600 milliliters for a patient weighing 70 kilograms. ABG shows pH 7.22, PaCO2 58 millimeters of mercury, PaO2 58 millimeters of mercury, on FiO2 0.80, PEEP is 8 centimeters of water. What should the nurse anticipate the provider ordering? Option A. Increase tidal volume to 800 milliliters to improve CO2 clearance. Option B. Reduce tidal volume to 6 milliliters per kilogram ideal body weight and increase PEEP. Option C. Decrease FiO2 to 0.60 and add bronchodilator therapy. Option D. Sedate and paralyze the patient to reduce oxygen consumption. Correct answer, B. ARDS management requires lung protective ventilation using low tidal volumes, 6 milliliters per kg, ideal body weight, 420 milliliters for this patient, to prevent ventilator-induced lung injury from barotrauma and volutrauma. Higher PEEP recruits collapsed alveoli and improves oxygenation. The current 600 milliliter tidal volume is injurious. Increasing tidal volume worsens lung damage. Reducing FiO2 is inappropriate when PaO2 is already critically low. A nurse is caring for a patient who received IV contrast dye for a CT scan 30 minutes ago. The patient now reports throat tightness and itching, has audible stridor, and urticaria is spreading across the trunk. BP is 8856 millimeters mercury. What is the nurse's priority intervention? Option A. Administer diphenhydramine 50 milligrams IV and notify the radiologist. Option B. Apply oxygen and prepare for IV corticosteroid administration. Option C. Administer epinephrine 0.3 milligrams IM into the anterolateral thigh immediately. Option D. Establish a second IV and bolus 1 liter normal saline for the hypotension. Correct answer, C. Stridor, urticaria, throat tightness, and hypotension following contrast administration indicate anaphylaxis, a life-threatening emergency requiring immediate IM epinephrine 0.3 to 0.5 milligrams into the anterolateral thigh. Epinephrine reverses bronchospasm, vasodilation, and angioedema simultaneously. Antihistamines and corticosteroids are adjunct therapies only and must never replace or delay epinephrine. IV fluid resuscitation follows epinephrine administration. A nurse is preparing to administer morning medications and notes a new order for ciprofloxacin 400 milligrams IV for a patient also receiving warfarin. The patient's current INR is 2.4. What is the most appropriate nursing action? Option A. Administer ciprofloxacin as ordered and monitor for infection resolution. Option B. Hold ciprofloxacin until the INR normalizes to below 2.0. Option C. Administer ciprofloxacin, notify the provider of the interaction, and anticipate increased INR monitoring. Option D. Contact pharmacy to substitute a non-fluoroquinolone antibiotic. Correct answer, C. Fluoroquinolones inhibit CYP1A2 and CYP3A4 enzymes, reducing warfarin metabolism and increasing anticoagulant effect, raising bleeding risk. The antibiotic is clinically necessary and should be administered, but the provider must be informed of the interaction. More frequent INR monitoring and possible warfarin dose reduction will be required. Substituting antibiotics is a provider decision, not a nursing action. Holding the antibiotic delays treatment of active infection. A nurse is caring for a patient with a traumatic brain injury whose ICP monitor reads 28 millimeters mercury. The patient's MAP is 82 millimeters mercury. Which value should the nurse calculate and report as most clinically significant? Option A, the ICP alone. Values above 20 millimeters mercury require immediate intervention. Option B, the cerebral perfusion pressure of 54 millimeters mercury, below the critical threshold. Option C, The pulse pressure widening indicates herniation risk. Option D, the mean arterial pressure. It is the sole driver of cerebral blood flow. Correct answer, B. Cerebral perfusion pressure, CPP, equals MAP minus ICP. 82 minus 28 equals 54 millimeters mercury, which is below the critical minimum of 60 to 70 millimeter mercury needed to maintain adequate cerebral blood flow. CPP is the most clinically significant value in TBI management. While elevated ICP alone is concerning, CPP drives treatment decisions. Interventions target both reducing ICP and maintaining MAP to optimize CPP and prevent secondary brain injury. A nurse is caring for a patient in active labor at 38 weeks. The fetal monitor shows a variable deceleration pattern. The nurse repositions the patient to the left lateral position with no improvement. What should the nurse do next? Option A, increase the IV oxytocin infusion to accelerate delivery. Option B, perform a vaginal examination to assess for umbilical cord prolapse. Option C, apply a fetal scalp electrode and continue monitoring. Option D, document the pattern and notify the provider at the next scheduled check. Correct answer B. Variable decelerations indicate umbilical cord compression. When repositioning fails to resolve them, the nurse must perform a sterile vaginal examination to assess for cord prolapse, an obstetric emergency where the cord precedes the presenting part and is compressed, causing fetal hypoxia. If prolapse is found, the nurse manually elevates the presenting part off the cord while calling for emergent cesarean delivery. Increasing oxytocin worsens cord compression. A nurse is caring for a patient with newly diagnosed myocardial infarction who suddenly becomes unresponsive. The cardiac monitor shows a sawtooth pattern at a rate of 280 per minute with no discernible QRS complexes. What is the priority intervention? Option A, administer amiodarone 300 mg IV push immediately. Option B, deliver unsynchronized defibrillation at 200 joules. Option C, initiate synchronized cardioversion at 100 joules. Option D, begin CPR and prepare transcutaneous pacing. Correct answer, B. A sawtooth pattern at 280 moment per minute with no identifiable QRS complexes describes ventricular flutter or coarse ventricular fibrillation, a non-perfusing rhythm requiring immediate unsynchronized defibrillation. Synchronized cardioversion requires a detectable R wave, which is absent. Amiodarone is administered after defibrillation in refractory VF, not as first-line treatment. Transcutaneous pacing is used for bradyarrhythmias, not tachyarrhythmias. A nurse is caring for a patient with a nasogastric tube receiving continuous enteral feeding at 60 milliliters per hour. During assessment, the nurse notes the patient has not had a bowel movement in 4 days, the abdomen is distended and firm, and bowel sounds are absent. Gastric residual volume is 480 milliliters. What is the nurse's priority action? Option A, administer the ordered PRN simethicone and reassess in 2 hours. Option B, stop the feeding, notify the provider, and withhold further enteral nutrition. Option C, flush the NG tube with 30 milliliters water and continue feeding at a reduced rate. Option D, reposition the patient to the right lateral decubitus position to facilitate gastric emptying. Correct answer B. A gastric residual of 480 milliliters with absent bowel sounds, abdominal distension, and no stool for 4 days indicates ileus or severely impaired gastric motility, a contraindication to continued enteral feeding due to aspiration risk. The feeding must be stopped and the provider notified immediately. Continuing at a reduced rate or repositioning does not address the underlying dysmotility. Provider evaluation is needed for prokinetic agents, imaging, or alternative nutritional support. A nurse is performing a skin assessment on a patient who has been bedridden for 5 days. Over the sacrum, the nurse observes an intact blister filled with serous fluid. There is no undermining or tunneling. Which stage of pressure injury does this represent? Option A, Stage 1, non-blanchable erythema of intact skin. Option B, Stage 2, partial thickness skin loss with exposed dermis. Option C, Stage 3, full thickness skin loss with visible subcutaneous tissue. Option D, unstageable, depth cannot be determined until debridement. Correct answer, B. A fluid-filled blister over a bony prominence represents a Stage 2 pressure injury, partial thickness skin loss, presenting as a blister or shallow open ulcer involving the epidermis and/or dermis. Stage 1 is intact skin with non-blanchable erythema. Stage 3 involves full thickness loss with visible fat. Unstageable injuries are covered by slough or eschar obscuring depth. Intact blisters are correctly classified as Stage 2. A nurse is caring for a patient who is 24 hours post-kidney transplant with urine output that has been 10 to 15 milliliters per hour for the past 3 hours. Creatinine has risen from 4.1 to 5.8 milligrams DCL. The patient is afebrile and hemodynamically stable. Cyclosporin trough is 380 nanograms per milliliter. Therapeutic 150 to 300 nanograms per milliliter. What is the most likely cause and appropriate action? Option A, acute rejection. Administer IV methylprednisolone pulse therapy. Option B, cyclosporin nephrotoxicity. Hold the dose and notify the transplant provider. Option C, hypovolemia. Administer 500 milliliters IV normal saline bolus. Option D, urinary obstruction. Irrigate the urinary catheter with sterile saline. Correct answer, B. Supratherapeutic cyclosporin, 380 nanograms per milliliter versus target 150 to 300 nanograms per milliliter, combined with oliguria and rising creatinine in an otherwise stable post-transplant patient, is consistent with calcineurin inhibitor nephrotoxicity, a dose-dependent cause of acute kidney injury. The dose must be held and the transplant provider notified for level reassessment. Rejection presents with tenderness over the graft and fever. Hypovolemia and obstruction are less consistent with the supratherapeutic drug level. A nurse is caring for a patient with schizophrenia who was involuntarily admitted following a psychotic episode. The patient refuses to take prescribed haloperidol. There is no court order for forced medication. What is the nurse's most appropriate action? Option A, administer the haloperidol in the patient's food without their knowledge. Option B, physically restrain the patient and administer the injection. Option C, document the refusal, notify the provider, and explore the reason for refusal. Option D, discharge the patient since involuntary holds do not permit forced medication. Correct answer, C. Involuntary psychiatric holds authorize detention for evaluation and safety. They do not automatically override the patient's right to refuse medication unless a court orders forced treatment. The nurse must document the refusal, notify the provider, and explore the patient's concerns, side effects, mistrust, delusion about medication. Covert administration is illegal and an ethical violation. Restraint for medication administration without court order constitutes assault. A nurse is caring for a patient receiving phenytoin 100 mg IV for seizure management. During administration, the nurse observes the IV site becoming swollen, pale, and painful. The infusion rate is 40 mg per minute. What should the nurse do first? Option A, slow the infusion rate to 25 mg per minute and apply warm compress to the site. Option B, stop the infusion immediately and assess the IV site for extravasation. Option C, flush the IV with normal saline to clear the line and continue at a lower rate. Option D, Notify the provider and document the finding before taking further action. Correct answer, B. Swelling, pallor, and pain at the IV site during phenytoin infusion indicate extravasation. Phenytoin is highly alkaline, pH normally 12, and causes severe tissue necrosis if it infiltrates. The infusion must be stopped immediately and the site assessed. The IV must be discontinued and a new site established. Phenytoin must never be infused faster than 50 milligrams per minute, and must be administered in normal saline, not dextrose, which causes precipitation. Flushing pushes the caustic agent further into tissue. A nurse is assessing a 3-year-old brought to the clinic for a well child visit. The parent reports the child has not yet said any 2-word phrases and does not engage in parallel play with other children. Which action by the nurse is most appropriate? Option A. Reassure the parent that children develop at different rates and recheck at age 4. Option B. Refer the child for developmental screening and notify the provider of findings. Option C. Recommend increased screen time with educational programming to stimulate language. Option D. Advise the parent to enroll the child in daycare to encourage peer interaction. Correct answer B. By age 2, children should use 2-word phrases. By age 3, they should speak in 3-word sentences and engage in parallel play. Absence of these milestones at age 3 represents significant developmental delay in both language and social domains. The nurse must refer for formal developmental screening, e.g., modified checklists for autism in toddlers, and notify the provider. Reassurance without evaluation delays diagnosis and early intervention. A nurse is caring for a patient with acute kidney injury, AKI. Current labs, BUN 68, creatinine 6.2, potassium 5.9, bicarbonate 14, phosphorus 7.1. The patient has decreased urine output and peripheral edema. Which prescribed diet order is most appropriate for this patient? Option A, high protein, low carbohydrate, and fluid as tolerated. Option B, low potassium, low phosphorus, low protein, and fluid restriction. Option C, high calorie, high protein, and sodium restriction only. Option D, low sodium, high potassium, and unrestricted fluid intake. Correct answer, B. AKI with hyperkalemia, hyperphosphatemia, acidosis, and fluid overload requires strict dietary management. Low potassium prevents fatal dysrhythmias. Low phosphorus prevents renal osteodystrophy. Protein restriction reduces BUN uremic solute load, and fluid restriction manages edema. High protein increases nitrogenous waste. Unrestricted potassium or fluids directly worsens the existing electrolyte and volume imbalances in this patient. A nurse working on a postpartum unit assesses a patient 8 hours after vaginal delivery. The fundus is firm, midline, and at the umbilicus. The patient has saturated 4 perineal pads in the past hour. What is the nurse's priority assessment? Option A. Assess lochia color and clots. Inspect the perineum for lacerations or hematoma. Option B. Massage the fundus vigorously to expel retained clots. Option C. Notify the provider and prepare for emergent uterine artery embolization. Option D. Administer the standing order for methylergonavine and reassess in 30 minutes. Correct answer, A. A firm fundus rules out uterine atony as the cause of heavy bleeding, indicating the source is likely a genital tract laceration or hematoma. The nurse must inspect the perineum, vagina, and cervix for lacerations and hematoma formation. Fundal massage is contraindicated when the uterus is already firm. Medications and provider notification follow identification of the bleeding source. Uterotonic agents do not address laceration-related hemorrhage. A nurse is caring for a patient on a psychiatric unit who has been pacing, clenching their fists, and making verbal threats toward staff for the past 20 minutes. The patient has not been violent yet. What is the nurse's best initial intervention? Option A, administer a PRN intramuscular haloperidol injection immediately. Option B, gather staff and approach the patient as a group to demonstrate control. Option C, approach the patient calmly, use a low voice, and offer to speak privately. Option D, initiate a restraint protocol and clear the area of other patients. Correct answer, C. De-escalation is always the first intervention for an escalating but not yet violent patient. Approaching calmly with a low, non-threatening voice, offering space, and acknowledging the patient's feelings can reduce agitation without escalating the situation. Gathering staff in a group increases the patient's perceived threat. Restraints and forced medications are last resorts, used only when verbal de-escalation has failed and safety is at immediate risk. A nurse is caring for a patient with Guillain-Barré syndrome, GBS, admitted 3 days ago with ascending weakness. The patient could walk on admission but now cannot lift either leg off the bed. Respiratory rate is 22 minutes, and the patient reports difficulty taking a deep breath. Vital capacity is measured at 14 milliliters per kilogram. What is the nurse's priority concern? Option A, progressive motor paralysis requiring physical therapy consultation. Option B, impending respiratory failure requiring provider notification and ventilator preparation. Option C, autonomic instability requiring continuous cardiac monitoring. Option D, pain management for neuropathic discomfort from nerve demyelination. Correct answer, B. In GBS, respiratory failure from diaphragm and intercostal muscle paralysis is the leading cause of death. Vital capacity below 20 mL per kg is the threshold for anticipating intubation. At 14 mL per kg with worsening dyspnea and tachypnea, respiratory failure is imminent. The provider must be notified immediately and mechanical ventilation prepared. While cardiac monitoring is important for autonomic instability, airway and breathing are the immediate life-threatening priorities. A nurse is caring for a patient in the ED with suspected carbon monoxide poisoning after being found unresponsive in a garage with an idling car. SpO2 on pulse oximetry reads 98%. The patient is confused with a headache. What is the most important nursing action? Option A, reassure the family SpO2 of 98% confirms adequate oxygenation. Option B, administer 100% oxygen via non-rebreather mask and notify the provider. Option C, obtain an arterial blood gas and await results before initiating oxygen. Option D, place the patient on 2 liters per minute nasal cannula oxygen and monitor neurological status. Correct answer, B. Pulse oximetry cannot distinguish carboxyhemoglobin, COHB, from oxyhemoglobin, so SpO2 reads falsely normal in CO poisoning. The clinical presentation, enclosed space exposure, confusion, and headache, confirms CO poisoning regardless of SpO2. High-flow 100% oxygen via non-rebreather mask is the immediate treatment to accelerate COHB dissociation, half-life reduced from 5 hours to 60 to 90 minutes. ABG with co-oximetry confirms COHB, but must not delay oxygen initiation. A nurse is caring for a 7-year-old child post-tonsillectomy. The child is now 6 hours post-op, and the parent reports the child has been swallowing repeatedly and frequently over the past 20 minutes. The child appears pale and restless. What should the nurse suspect and do? Option A, the child is experiencing post-op nausea. Administer ondansetron as ordered. Option B, the child has post-tonsillectomy hemorrhage. Notify the surgeon immediately. Option C, the child is anxious about being in the hospital. Provide reassurance and distraction. Option D, the child is thirsty from NPO status. Offer clear cold liquids immediately. Correct answer, B. Frequent swallowing in a post-tonsillectomy child is a critical sign of hemorrhage. The child is swallowing blood from the operative site. Pallor and restlessness support hemodynamic compromise. This is a surgical emergency requiring immediate surgeon notification and preparation for possible return to the OR. Offering fluids, antiemetics, or reassurance without assessing for bleeding delays recognition of a potentially fatal complication. A nurse is discharging a patient with newly prescribed nitroglycerin sublingual tablets for stable angina. Which patient statement indicates correct understanding? Option A. I can take up to 5 tablets spaced 10 minutes apart before calling for help. Option B. I should store my nitroglycerin in a clear plastic container near a window for easy access. Option C. If my chest pain is not relieved after 3 tablets 5 minutes apart, I need to call 911. Option D. I should take a nitroglycerin tablet before every meal to prevent angina attacks. Correct answer, C. The correct protocol is 1 sublingual nitroglycerin tablet every 5 minutes for up to 3 doses. If pain persists after 3 tablets, the patient must call 911 for possible MI. 5 tablets over 10-minute intervals delays emergency response. Nitroglycerin must be stored in the original dark glass bottle away from heat and light. Clear plastic containers and sunlight degrade the medication. Prophylactic pre-meal dosing is not standard practice for stable angina. A nurse is caring for a patient with cirrhosis who develops hematemesis. The patient is vomiting bright red blood and is tachycardic with BP 82/54 mmHg. 2 large-bore IVs are in place. What intervention should the nurse prioritize? Option A. Insert an NG tube and perform gastric lavage with iced saline. Option B. Prepare for endoscopy and administer octreotide and IV fluid resuscitation. Option C. Administer lactulose 30 ml via NG tube to prevent hepatic encephalopathy. Option D. Transfuse 2 units of fresh frozen plasma for the coagulopathy. Correct answer, B. Hematemesis with hemodynamic instability in a cirrhotic patient indicates variceal bleeding, a life-threatening emergency. Octreotide reduces portal pressure and variceal bleeding. Urgent endoscopy achieves definitive hemostasis via banding or sclerotherapy. IV fluid resuscitation stabilizes hemodynamics. Iced gastric lavage is no longer evidence-based. Lactulose does not address active hemorrhage. FFP may be needed, but is secondary to vasoactive therapy and endoscopic control. A nurse is caring for a patient with a new colostomy following sigmoid colon resection. On day 3, the stoma appears pale pink and slightly dusky at the edges. What is the nurse's most appropriate action? Option A. Apply warm, moist cloths to the stoma to improve circulation. Option B. Document the finding as expected postoperative stoma appearance. Option C. Notify the provider. Stoma color indicates compromised perfusion. Option D. Instruct the patient to increase ambulation to improve blood flow. Correct answer, C. A healthy stoma should be beefy red and moist. A pale, dusky, or dark stoma indicates ischemia from compromised vascular supply, a surgical emergency requiring immediate provider notification. Dusky coloring on day 3 is not expected. Early recognition and intervention may prevent stoma necrosis. Warm compresses do not restore vascular perfusion. Documentation without escalation and encouraging ambulation are both inappropriate responses to vascular compromise. A nurse is assessing pain in a 4-year-old child following an appendectomy. The child is lying still, has a furrowed brow, and refuses to move or eat. When asked about pain, the child says no. Which action should the nurse take? Option A. Accept the child's verbal report and continue routine monitoring. Option B. Administer the PRN analgesic based on behavioral pain indicators. Option C. Reassess pain in 2 hours after the child rests. Option D. Ask the parents to determine if the child appears to be in pain. Correct answer, B. Young children commonly deny pain to avoid injections or unknown interventions. Behavioral indicators, lying still, facial guarding, refusal to move or eat, are reliable signs of pain in a child who cannot reliably self-report. Evidence-based pediatric pain assessment tools, FLACC scale, use behavioral cues, not verbal report alone. The nurse should administer the PRN analgesic based on the behavioral assessment. Waiting delays pain relief and impairs recovery. A nurse is preparing to administer a scheduled dose of insulin glargine 20 units subcutaneously to a patient whose blood glucose is 62 milligrams per deciliter. What should the nurse do? Option A. Administer the full dose. Basal insulin does not affect acute glucose levels. Option B. Hold the insulin glargine, treat the hypoglycemia, and notify the provider. Option C. Reduce the dose to 10 units and administer after giving a snack. Option D. Administer insulin glargine and simultaneously start a 10% dextrose infusion. Correct answer, B. A blood glucose of 62 milligrams per deciliter is hypoglycemia. Administering any insulin, including basal, glargine, in a hypoglycemic patient deepens the hypoglycemia and is unsafe. The nurse must withhold the insulin, treat the hypoglycemia with 15 grams of fast-acting carbohydrate or IV dextrose based on patient consciousness, recheck glucose, and notify the provider. Splitting the dose or running dextrose concurrently does not constitute safe practice. Provider guidance is required. A nurse is caring for a patient being treated for tuberculosis with isoniazid, rifampin, ethambutol, and pyrazinamide. The patient reports numbness and tingling in both feet. Which medication is most likely responsible? Option A, rifampin, causes peripheral neuropathy through folate antagonism. Option B, isoniazid, causes peripheral neuropathy through vitamin B6 depletion. Option C, ethambutol, causes optic neuritis and peripheral neuropathy. Option D, pyrazinamide, causes hyperuricemia and peripheral joint pain. Correct answer, B. Isoniazid inhibits pyridoxine vitamin B6 metabolism, causing peripheral neuropathy. Bilateral distal tingling and numbness are classic presentations. Pyridoxine 25 to 50 milligrams per day is co-prescribed prophylactically to prevent this. Ethambutol causes optic neuritis, vision changes, color blindness, not peripheral neuropathy. Rifampin causes hepatotoxicity and body fluid discoloration. Pyrazinamide causes hyperuricemia and hepatotoxicity, not peripheral neuropathy. A nurse is caring for a patient with a pulmonary artery catheter. The nurse notes the waveform on the monitor has changed from a pulmonary artery waveform to a continuous wedge waveform. What is the priority action? Option A, reposition the patient to the left lateral position to correct the waveform. Option B, notify the provider. The catheter has migrated distally and risks pulmonary infarction. Option C, flush the catheter with a rapid saline bolus to reposition the tip. Option D, deflate the balloon and document the waveform change in the chart. Correct answer, B. A spontaneously wedged pulmonary artery catheter, persistent wedge waveform without balloon inflation, indicates the catheter has migrated too far distally. A wedged catheter obstructs pulmonary blood flow, risking pulmonary infarction and arterial rupture. The provider must be notified immediately for catheter repositioning. The nurse should not rapidly flush a wedged catheter, as it can cause vessel rupture. The balloon must remain deflated until the provider repositions the catheter. A nurse is caring for a 2-day-old neonate born at 36 weeks gestation. The infant has been exclusively breastfeeding. The mother states the infant feeds for only 5 minutes before falling asleep and has had only 2 wet diapers in 24 hours. The infant's weight is down 9% from birth weight. What is the nurse's priority action? Option A. Reassure the mother that weight loss up to 10% is normal in newborns. Option B. Notify the provider. The feeding pattern and output suggest inadequate intake and dehydration risk. Option C. Recommend switching to formula to ensure adequate caloric intake. Option D. Encourage the mother to increase feeding frequency to every 4 hours. Correct answer, B. A late preterm neonate, 36 weeks, has immature sucking reflexes and is at high risk for feeding failure and dehydration. Feeding only 5 minutes per session, with only 2 wet diapers in 24 hours, expected 6 to 8, and 9% weight loss approaching the 10% concern threshold, requires provider notification and lactation evaluation. Late preterm infants are deceptively difficult feeders and can deteriorate rapidly. Reassurance without escalation in this population is unsafe. A nurse is caring for a patient recovering from a lumbar puncture performed 2 hours ago. The patient reports a severe positional headache that worsens when sitting up and improves when lying flat. What complication has occurred, and what is the priority nursing action? Option A. Meningeal irritation. Administer prescribed acetaminophen and monitor. Option B. Post-dural puncture headache. Keep the patient supine, encourage fluids, and notify the provider. Option C. Intracerebral hemorrhage. Notify the provider and prepare for emergent CT. Option D. Vasovagal response. Elevate the legs and administer IV atropine. Correct answer, B. A positional headache, worse upright, relieved supine, after lumbar puncture is classic post-dural puncture headache, PDPH, caused by CSF leakage through the dural puncture site, reducing intracranial pressure. Management includes supine positioning, hydration, caffeine, and analgesics. If symptoms persist beyond 24 to 48 hours, an epidural blood patch is definitive treatment. This is not hemorrhage, which presents with non-positional severe headache. Provider notification ensures appropriate follow-up. A nurse is caring for a patient with type 1 diabetes who takes insulin glargine nightly and insulin lispro with meals. The patient is admitted for pneumonia and placed on NPO status. What is the most appropriate management of insulin orders? Option A. Hold all insulin since the patient is NPO and glucose management is unnecessary. Option B. Continue the basal insulin glargine and hold mealtime lispro. Monitor glucose every 4 to 6 hours. Option C. Switch the patient to a sliding scale of regular insulin with meals only. Option D. Administer both glargine and lispro on the scheduled times regardless of NPO status. Correct answer, B. Patients with type 1 diabetes always require basal insulin, even when NPO. Omitting it risks diabetic ketoacidosis, since there is no endogenous insulin production. Mealtime bolus insulin is appropriately held when the patient is not eating. Blood glucose monitoring every 4 to 6 hours enables correction dosing as needed. Holding all insulin in T1DM is a critical error. Sliding scale alone is insufficient for type 1 diabetes management during illness. A nurse is educating a patient about self-administration of enoxaparin following hip replacement surgery. Which patient demonstration indicates a need for reteaching? Option A. The patient selects the lateral abdomen as the injection site, alternating sides. Option B. The patient aspirates the syringe plunger before injecting to confirm placement. Option C. The patient pinches a skin fold and injects at a 90-degree angle. Option D. The patient holds pressure at the site after injection without rubbing. Correct answer, B. Aspiration before subcutaneous injection is not recommended. It is unnecessary for subcutaneous injections and increases bruising and tissue trauma at the site. This is a critical technique error requiring reteaching. The lateral abdomen alternating sides, 90-degree angle with skin pinch, and gentle post-injection pressure, without rubbing, which disperses medication and worsens bruising, are all correct subcutaneous injection techniques. A nurse is caring for a patient with Cushing's syndrome admitted for adrenal workup. The nurse is reviewing the patient's assessment findings. Which combination of findings is most consistent with this diagnosis? Option A, weight loss, hypotension, hyperpigmentation, and hyponatremia. Option B, truncal obesity, hypertension, moon face, and purple abdominal striae. Option C, exophthalmos, heat intolerance, diarrhea, and fine hair texture. Option D, coarse hair, cold intolerance, bradycardia, and periorbital edema. Correct answer. B. Cushing's syndrome results from chronic glucocorticoid excess causing truncal obesity, hypertension, from mineralocorticoid effects, moon face, fat redistribution, buffalo hump, and purple stria from skin thinning and protein catabolism. Option A describes Addison's disease, adrenal insufficiency. Option C describes hyperthyroidism. Option D describes hypothyroidism. Recognizing the distinguishing features of each endocrine disorder is essential for accurate clinical reasoning. A nurse is caring for a patient who underwent a thyroid storm triggered by emergency surgery. The patient has a temperature of 40.8 degrees Celsius, HR 148 ppm with atrial fibrillation, and is extremely agitated. The nurse anticipates which combination of interventions. Option A, IV propranolol, propylthiouracil, hydrocortisone, and cooling measures. Option B, IV methimazole, radioactive iodine, and external warming. Option C, thyroidectomy preparation, lithium carbonate and fluid restriction. Option D, IV levothyroxine, amiodarone, and antipyretics only. Correct answer, A. Thyroid storm management targets all components simultaneously. Propranolol controls tachycardia, atrial fibrillation, and blocks T4 to T3 conversion. Propylthiouracil blocks new thyroid hormone synthesis and T4 to T3 conversion. Hydrocortisone treats relative adrenal insufficiency and further blocks conversion. And cooling measures reduces hyperthermia. Iodine solution, Lugol's, is also given after PTU. Levothyroxine and radioactive iodine are contraindicated in thyroid storm. Both increase thyroid hormone levels or activity. A nurse is caring for a patient in the oncology clinic receiving a third cycle of doxorubicin-based chemotherapy. The patient's cumulative doxorubicin dose is now 450 milligrams per square meter. The patient reports new onset dyspnea on exertion and bilateral ankle swelling. What does the nurse suspect, and what is the priority action? Option A, pleural effusion from metastatic disease, prepare for thoracentesis. Option B, doxorubicin-induced cardiomyopathy, hold the infusion and notify the oncologist. Option C, pulmonary embolism from hypercoagulable cancer state, initiate anticoagulation workup. Option D, anemia from bone marrow suppression, check CBC and arrange transfusion. Correct answer, B. Doxorubicin causes cumulative, dose-dependent cardiotoxicity, cardiomyopathy, heart failure, with risk significantly increasing above 400 to 550 milligrams per squared. New dyspnea and bilateral edema at 450 milligrams per squared strongly suggest anthracycline-induced cardiomyopathy. The infusion must be held, and the oncologist notified for echocardiogram evaluation before any further doxorubicin administration. PE and anemia are possible, but are not the priority explanation given the cumulative cardiotoxic dose threshold reached. A charge nurse is making patient assignments for the upcoming shift. Which patient is most appropriate to assign to a licensed practical nurse, LPN? Option A, a patient with septic shock requiring titration of vasopressors and hourly assessment. Option B, a patient 2 hours post-CABG with hemodynamic instability and chest tube drainage. Option C, a patient with stable chronic heart failure receiving oral medications and awaiting discharge. Option D, a patient newly admitted with altered mental status and suspected meningitis. Correct answer. C. LPNs provide care for stable patients with predictable outcomes. Medication administration, routine assessments, and discharge preparation are within their scope. Septic shock vasopressor titration, immediate post-CABG monitoring, and new admissions with unstable neurological status require the assessment skills and clinical judgment of a registered nurse. Assignment decisions must match patient acuity and complexity with the licensee's legally defined and competency-based scope of practice. A nurse is reviewing a patient's 12-lead ECG and notes ST segment elevation in leads V1 to V4, reciprocal ST depression in leads 2, 3, and AVF, and new left bundle branch block. The patient is diaphoretic and reports chest pressure. What is the nurse's immediate priority? Option A, administer sublingual nitroglycerin and reassess pain in 5 minutes. Option B, obtain serial troponin levels and repeat ECG in 30 minutes before notifying the provider. Option C, activate the STEMI protocol and notify the interventional cardiology team. Option D, administer IV morphine and metoprolol per standing order. Correct answer, C. ST elevation in V1 to V4 indicates anterior STEMI, LAD territory, the most hemodynamically dangerous STEMI territory. New LBBB in the setting of chest pain is treated as STEMI equivalent. The STEMI protocol must be activated immediately for primary PCI within 90 minutes, door-to-balloon time. Serial troponins are obtained in parallel, not before action. Nitroglycerin and morphine are secondary and must not delay reperfusion activation. A nurse is caring for a patient with chronic pain on a scheduled fentanyl 75 mcg per hour transdermal patch, who reports breakthrough pain rated 8 to 10. The PRN order is for oral oxycodone 5 mg. Before administering, which assessment is most critical? Option A, time of last bowel movement. Opioids cause constipation. Option B, current respiratory rate and level of sedation. Option C, patient's pain rating 30 minutes prior to current report. Option D, date the fentanyl patch was last changed. Correct answer, B. The patient is already receiving a high-dose baseline opioid, 75 mg per hour fentanyl patch, and is requesting additional opioid. Respiratory depression and oversedation are the primary safety concerns before stacking opioid doses. Respiratory rate and sedation level must be assessed before administering any additional opioid. Constipation, prior pain ratings, and patch change dates are relevant, but do not carry the same immediate safety urgency as respiratory assessment before adding breakthrough analgesia. A nurse receives a phone call from a person who identifies themselves as a detective, requesting information about a patient's admission status and injuries for an ongoing investigation. The nurse has not been able to verify the caller's identity. What should the nurse do? Option A, provide the requested information since law enforcement has authority to access medical records. Option B, decline to confirm or deny patient information and direct the caller to the facility's privacy officer. Option C, confirm only the patient's admission status, as this is considered directory information. Option D, transfer the call to the patient's nurse to decide what information to share. Correct answer, B. HIPAA requires verification of identity and valid legal authorization, subpoena, court order, or written patient authorization before disclosing PHI to law enforcement. A verbal phone request alone is insufficient. The nurse must decline to confirm or deny any information and direct the caller to the facility's HIPAA privacy officer. Confirming admission status without verification still constitutes a potential HIPAA violation. Transferring the call does not transfer the legal obligation. A nurse is caring for a patient who is 5 days post-op abdominal surgery. While ambulating the patient to the bathroom, the patient reports a sudden sensation of something giving way in the abdomen. The nurse inspects the wound and observes loops of bowel protruding through the incision. What is the nurse's immediate action? Option A. Apply an abdominal binder firmly and call for help. Option B. Attempt to replace the bowel and apply a dry sterile dressing. Option C. Cover the bowel with sterile saline moistened gauze, keep the patient supine, and call for help. Option D. Position the patient in Trendelenburg and apply a firm pressure dressing. Correct answer, C. Evisceration, protrusion of abdominal contents through a wound, is a surgical emergency. The exposed bowel must be covered immediately with sterile saline moistened gauze to prevent desiccation, infection, and necrosis. Never replaced by the nurse. The patient is placed supine with knees slightly flexed to reduce tension. Emergency surgery is required. Abdominal binders and Trendelenburg positioning are inappropriate. Dry dressings damage exposed bowel tissue. A nurse is caring for a patient with heart failure who has been prescribed spironolactone 25 mg daily. Which laboratory finding requires the nurse to hold the medication and contact the provider? Option A. Sodium 136 MEQ liter. Option B. Potassium 5.6 MEQ liter. Option C. BUN 22 mg DLE. Option D. Creatinine 1.2 mg DLE. Correct answer, B. Spironolactone is a potassium-sparing diuretic. Its primary adverse effect is hyperkalemia. A potassium of 5.6 milliequivalent per liter exceeds the upper limit of normal, 5.0 milliequivalent per liter, and poses a risk for life-threatening cardiac dysrhythmias. The medication must be held and the provider notified. The other values are within normal limits and do not contraindicate spironolactone administration. Potassium levels must be closely monitored in all patients on potassium-sparing diuretics. A nurse is caring for a patient in alcohol withdrawal who is on a CWA-R protocol. The patient's current CWA-R score is 18. The patient is tremulous, diaphoretic, and mildly confused. What is the nurse's priority intervention? Option A. Continue scheduled monitoring and reassess CWA-R score in 4 hours. Option B. Administer the PRN lorazepam per protocol and increase monitoring frequency. Option C. Apply physical restraints to protect the patient from injury during withdrawal. Option D. Notify the provider only if the score exceeds 20. Correct answer, B. A CWA-AR score of 18 indicates severe alcohol withdrawal. Scores equal 10 typically trigger PRN benzodiazepine administration per protocol. Lorazepam or diazepam reduces CNS excitability, preventing seizures and delirium tremens progression. Monitoring frequency must be increased. Restraints do not treat withdrawal physiology. Waiting until score exceeds 20 delays pharmacological intervention that could prevent life-threatening complications. A nurse is caring for a patient with newly diagnosed bipolar I disorder who is being started on valproic acid. Which laboratory test is most important to obtain before initiating therapy? Option A. Serum lithium level. Option B. Liver function tests and complete blood count. Option C. Thyroid stimulating hormone level. Option D. Fasting lipid panel. Correct answer, B. Valproic acid, valproate, carries risks of hepatotoxicity and thrombocytopenia. Baseline liver function tests and CBC must be obtained before initiation to identify pre-existing dysfunction and establish reference values for monitoring. LFTs and CBC are also monitored periodically throughout therapy. TSH is a priority baseline for lithium therapy, not valproate. Lithium levels are irrelevant before starting a different mood stabilizer. Lipid panels are not specifically indicated pre-valproate. A nurse is caring for a patient on a ventilator when the high-pressure alarm sounds continuously. The patient appears anxious, is using accessory muscles, and SpO2 is dropping to 88%. What should the nurse assess first? Option A, check for water accumulation in the ventilator circuit tubing. Option B, assess for patient ventilator dysynchrony and check for kinked tubing or airway obstruction. Option C, increase the FiO2 to 100% and silence the alarm. Option D, suction the endotracheal tube immediately without further assessment. Correct answer, B. A continuous high-pressure alarm with patient distress indicates increased resistance to airflow. Causes include kinked tubing, secretion obstruction, biting on the ET tube, bronchospasm, or pneumothorax. The nurse must systematically assess the circuit and airway before acting. While suctioning may be appropriate if secretions are suspected, doing so before identifying the cause risks harm, e.g., suctioning during bronchospasm or tension pneumothorax. Increasing FiO2 without addressing the cause is insufficient. A nurse is caring for a patient with bacterial endocarditis receiving IV vancomycin and gentamicin. After 5 days of therapy, the patient's creatinine has risen from 0.9 to 2.4 milligrams per deciliter, and urine output has decreased. Which conclusion should the nurse draw? Option A, the patient is developing acute tubular necrosis from bacterial toxins. Option B, the antibiotic combination is causing nephrotoxicity, requiring provider notification. Option C, the creatinine rise reflects normal renal compensation to infection. Option D, volume depletion from fever is the most likely cause of rising creatinine. Correct answer B. Both vancomycin and gentamicin are independently nephrotoxic. When combined, their toxicity is synergistic and significantly increases the risk of acute kidney injury. Rising creatinine and oliguria after 5 days of dual nephrotoxic therapy is a classic presentation of drug-induced nephrotoxicity. The provider must be notified for dose adjustment, drug level monitoring, or antibiotic substitution. This is not compensatory or expected. It is a serious adverse drug reaction. A nurse is performing a home visit for an 82-year-old patient with moderate dementia who lives alone. The nurse observes expired food in the refrigerator, an empty medication organizer midweek with pills scattered on the counter, an unlocked firearm on a shelf, and several fall hazards throughout the home. What is the nurse's priority safety concern? Option A, medication non-adherence from cognitive decline. Option B, nutritional risk from consuming expired food. Option C, the unlocked firearm accessible to a cognitively impaired individual. Option D, fall risk from environmental hazards. Correct answer, C. While all findings represent significant safety concerns, an unlocked, accessible firearm in the home of a cognitively impaired individual poses the most immediate risk of lethal harm to the patient and potentially to others. Cognitive impairment eliminates reliable judgment about firearm safety. The nurse must address this immediately with the family or appropriate authority. The other safety concerns, though urgent, do not carry the same potential for immediate fatal outcome. A nurse is caring for a patient receiving IV amphotericin B for a systemic fungal infection. 30 minutes into the infusion, the patient develops chills, fever of 39.1 degrees Celsius, and rigors. BP is stable. What is the most appropriate nursing action? Option A, stop the infusion permanently and document a drug reaction. Option B, slow the infusion rate, administer prescribed premedications, and notify the provider. Option C, administer epinephrine. This is an anaphylactic reaction, requiring emergency management. Option D. Switch to the oral formulation of antifungal therapy immediately. Correct answer. B. Infusion-related reactions. Chills, fever, rigors during amphotericin B administration are common, expected, non-immunologic reactions, not anaphylaxis. Standard management includes slowing the infusion rate and administering pre-medications such as acetaminophen, diphenhydramine, meperidine for rigors, and hydrocortisone. The infusion is not permanently discontinued for typical infusion reactions. Epinephrine is for anaphylaxis, which presents with bronchospasm, urticaria, and hemodynamic collapse. A nurse is reviewing medication orders for a patient admitted with a hypertensive emergency. BP is 226, 134 mmg. The patient is alert with no neurodeficits, no chest pain, and no renal failure, classified as a hypertensive urgency. The provider orders oral labetalol. The patient asks why blood pressure is not being lowered right away. What is the most accurate response? Option A. We want to avoid giving IV medications unless absolutely necessary. Option B. Lowering your blood pressure too quickly can reduce blood flow to the brain and cause a stroke. Option C. Oral medications work faster for high blood pressure than IV medications. Option D. We need more lab results before we can safely treat your blood pressure. Correct answer B. In hypertensive urgency without end organ damage, rapid BP reduction is avoided because cerebral autoregulation has adapted to chronically elevated pressures. Sudden normalization can critically reduce cerebral perfusion, causing ischemic stroke. The goal is gradual reduction of 25% over 24 to 48 hours with oral agents. Hypertensive emergency with end organ damage requires IV agents and controlled reduction. This is a critical distinction between urgency and emergency management. A nurse is preparing to perform a sterile dressing change on a patient's abdominal wound. After opening the sterile field and donning sterile gloves, the nurse's right glove touches the bedside rail while reaching for supplies. What should the nurse do? Option A. Wipe the contaminated glove with a sterile gauze pad and continue. Option B. Remove both gloves, re-perform hand hygiene, and re-glove with a new sterile pair. Option C. Change only the contaminated right glove and proceed with the dressing change. Option D. Continue the dressing change using the left hand only. Correct answer B. Any contact between a sterile glove and a non-sterile surface constitutes contamination. Sterile technique requires both gloves to be removed, hand hygiene performed, and a new sterile pair donned before proceeding. Wiping with sterile gauze does not restore sterility. Changing only one glove risks contaminating the new glove during the single glove exchange process. Performing the dressing with one hand is clinically impractical and maintains contamination risk. A nurse is caring for a patient admitted with severe preeclampsia at 34 weeks gestation. The patient is receiving magnesium sulfate and labetalol. The patient reports blurred vision and a severe frontal headache rated 9 out of 10. Reflexes are 3+ bilaterally. BP is 168, 110 millimeters of mercury. What is the nurse's priority action? Option A. Administer a PRN dose of oral acetaminophen for the headache. Option B. Notify the provider immediately. The patient is showing signs of impending eclampsia. Option C. Increase the magnesium sulfate infusion rate by 1 gram per hour. Option D. Reassess BP in 30 minutes and document the neurological symptoms. Correct answer B. Blurred vision, severe frontal headache, and hyperreflexia 3+ with persistent hypertension despite treatment are premonitory signs of eclamptic seizure. The provider must be notified immediately for assessment and possible delivery, the only cure for preeclampsia, eclampsia. Magnesium infusion changes require a provider order and should not be made independently. Reassessment delay risks eclamptic seizure with maternal and fetal mortality. Acetaminophen does not address the underlying pathology. A nurse is caring for a patient with a new above-knee amputation. The patient states, "I still feel pain in my foot, the one that was removed." Which response by the nurse is most appropriate? Option A, "That's not possible. The limb is gone, so there are no pain signals." Option B, "You may be experiencing phantom limb pain, which is a real neurological phenomenon." Option C, "This is likely referred pain from the incision site. It will resolve as you heal." Option D, "This means your nervous system is recovering well from the surgery." Correct answer, B. Phantom limb pain is a well-documented neurological phenomenon in which the brain continues to receive and process pain signals from the absent limb via residual nerve pathways. It is not psychosomatic or imaginary, and dismissing it undermines the therapeutic relationship. Treatment options include mirror therapy, medications, gabapentin, TCAs, and nerve blocks. The nurse's response must validate the patient's experience with accurate clinical information. A nurse is performing discharge teaching for a patient with a new permanent pacemaker implanted for symptomatic bradycardia. Which patient statement indicates a need for further instruction? Option A, "I should carry my pacemaker identification card at all times." Option B, "I can use my cell phone as long as I hold it on the opposite side from my pacemaker." Option C, "I can go through airport security metal detectors without any concern." Option D, "I should avoid placing magnets near my pacemaker." Correct answer, C. Airport security metal detectors and full-body scanners can detect pacemakers and may activate alarms. Patients should inform security personnel and request hand screening. More importantly, security screening devices in some settings may interfere with pacemaker function. Patients should present their pacemaker ID card to security. Cell phone use on the opposite side is correct. Avoiding magnets is correct. They can switch the pacemaker to fixed-rate asynchronous mode. Carrying the ID card is essential. A nurse is caring for a patient with a history of opioid use disorder who is admitted for a femur fracture. The patient is prescribed buprenorphine naloxone, Suboxone, as maintenance therapy. The patient reports severe pain rated 9-10 after surgery. The surgical team is reluctant to prescribe additional opioids. What is the most appropriate nursing action? Option A, advocate for a multimodal analgesia plan and pain management or addiction medicine consultation. Option B, encourage the patient to tolerate the pain since opioids are contraindicated with Suboxone. Option C, hold the Suboxone and request full opioid agonist therapy for post-surgical pain. Option D, administer only NSAIDs and non-pharmacologic measures without escalating to the provider. Correct answer, A. Patients on buprenorphine maintenance therapy have complex analgesic needs. Buprenorphine's partial agonism and high mu receptor affinity reduce standard opioid efficacy. Adequate post-surgical pain management is both ethically required and clinically necessary. The nurse must advocate for the patient by requesting addiction medicine or pain management consultation for a multimodal plan, regional anesthesia, ketamine, NSAIDs, adjusted buprenorphine dosing. Undertreating pain in this population risks relapse and violates patient rights. Great work. Review the questions you missed. Consistent practice is one of the best ways to prepare for the NCLEX-RN. If you found this exam helpful, subscribe to MedPrep Prime for more NCLEX practice questions. Check the playlist for additional mock exams and topic-based quizzes, and continue testing your knowledge daily. Thanks for studying with MedPrep Prime, and good luck on your NCLEX.